Hello guys, let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're gonna talk about the septic pulmonary embolism, radiologic findings of septic pulmonary embolism, chapter 72. We see two CAT scan images of septic lung emboli, variable-sized ill-defined nodules, some with cavity, some without cavity, and peripheral lower lobe dominancy, some with pleural effusion. Let's go. Septic pulmonary embolism, SPE, is defined as an embolization of infectious particles, intravascular thrombus containing microorganisms into the lung via pulmonary arteries. Clinical presentations. Clinical features. In many cases, they are nonspecific, not indicating that the name of the disease is septic pulmonary embolism. Not specific, mostly as bacteremia. The symptoms of bacteremia, such as dyspnea, chest pain, cough, and other respiratory symptoms. Of course, the primary focal symptoms, such as liver abscess symptoms, are present. The common primary sites of the septic pulmonary embolisms are right-sided infective endocarditis, most commonly from trachea valve and secondary from pulmonary valve, and infection elsewhere with cardiac septal defects and infected deep vein thrombosis, and also with infected venous catheters or lines, such as central lines, and also with pacemaker wires and periodontal infection and liver abscess. Many of the organisms, bacterial organisms, can be the source of septic pulmonary embolism, but among them, two most famous organisms are these. First, Klebsiella pneumonia and Staph aureus. They are two most famous, notorious organisms. Chest X-ray findings of septic pulmonary embolisms are like this. As I told you before, they are usually non-specific, not specifically indicating septic pulmonary embolism. The usual features are diffuse bilateral nodules in varying stages of cavitation, poorly marginated peripheral dominance, lower lobe dominance. The nodules are from 1 to 3 centimeters in varying size because they came from repeated embolic shower. Repeated embolic shower is the cause of a varying size. Increased in number or change in shape, in size, and in cavitation on short-term follow-up images. And also they may have pleural effusion. Chest CAT scan findings of septic pulmonary embolism. These findings are same as chest X-ray findings. Bilateral, up to 80% of the patients show us bilateral distribution of the nodules. And feeding vessel sign, I'll talk to you later. And 3, peripheral nodules, some with cavities, some without cavities. And peripheral wedge-shaped densities, it means usually septic pulmonary infarcts, maybe cavitary, lower dominancy. Always we need differential diagnosis. Number 1 is many other infectious lung disease. And second, hematogenous lung metastasis. Sometimes it's very hard to differentiate between lung metastasis and septic pulmonary embolism. Sir, you subscribed and said good to me. Merci. Be happy and healthy. Thank you very much. Let's enjoy the wonderful non-specific findings of septic pulmonary embolism. First one is from liver abscess. The germ is Klebsiella pneumonia of liver abscess. You can see the liver abscess on the right side. Liver CT, the black ovoid one is liver abscess. On the left side film, chest radiograph shows us many ill-defined variable-sized nodules, peripheral dominance, bilateral distribution. These three CAT scan images show us bilateral, many, ill-defined, from 1 to 3 centimeters in size, peripheral dominance, lower lobe dominance, septic pulmonary embolism. And at the axial CT left below, we see the cavitation. The white arrow indicates the cavitation and bilateral small pleural effusion too. How about the second case of the liver CT? In his right liver, we see a few low-density areas of a multiple liver abscess. That's the primary focus of septic pulmonary emboli. In his chest CT, we see several nodules of ill-defined margin from 1 to 3 centimeter varying size, peripheral, lower lobe dominance, and bilateral distribution. These nodules are septic pulmonary emboli. Now it's time to talk about the feeding vessel signs of septic pulmonary emboli. The feeding vessel sign actually once upon a time sign, not true sign, not proved sign, not anymore sign, not correct sign. It was proved as inaccurate in year 2006 at American Journal of Radiology by Dr. Jonathan Dodd et al. With name of High Resolution MDCT of Pulmonary Septic Embolism, Evaluation of the Feeding Vessel Sign. Their conclusion was, although pulmonary septic emboli often appear to have a feeding vessel on conventional cross-sectional images, multi-planar reconstructions show that most of these vessels course around the nodule, not through the nodule, and that the others are pulmonary veins, not pulmonary arteries. Others are pulmonary veins. So it is not correct anymore, and it is also not useful anymore. Please forget the name of a feeding vessel sign. How about this chest radiograph of AP supine view? What do we see? Yes, many bilateral, ill-defined, variable-sized nodules of peripheral distribution, bilateral distribution, septic pulmonary embolism. These three CAT scan images show us several septic embolism of feeding vessel sign. Please look these yellow circles. They are indicating us feeding vessel sign, feeding pulmonary arteries, but actually they are not going through the nodule. They go around the nodule or they are pulmonary veins. How do you feel now? The septic pulmonary embolism findings are over now. Thank you for watching. See you soon. You quit smoking? Wonderful. God bless you.